Our speaker today is Dr. Cangiano. I work closely with him in Orlando. He has been a physician for over 25 years in the Orlando area. He practices urologic oncology and male hormone replacement. Dr. Cangiano is also the author of the book, The Myths and Reality of Testosterone, a simple and practical guide to get you back in the game. And most recently, a book on prostate cancer. So please give him a warm welcome, Dr. Cangiano.
All right, adrenal masses, they can be scary. One of the things when we're interns and residents is adrenal masses, how do you work those up, and all these complicated tests and complicated blood tests and urine tests, and how do you work these up, and what do you do? Well, I'm here to make your life simple. There's pretty much 8 labs you need to know about, and that'll be the last slide. So we'll go through all this, but just recognize that, especially if you're an epic, there's only 8 labs you need to know about. And we'll go in those at the end, and that'll be the simplest way to work up 99% of adrenal masses, okay? So it's not that complicated as you think. It's actually become simplified. Technology is better. Back in my day, we didn't know what was going on, and it was kind of difficult to diagnose. So the anatomy of the adrenal gland, the adrenal sits on top of the kidney, as you know. It has a cortex and medulla. The medulla forms epinephrine and norepinephrine. The cortex forms cortisol, aldosterone, and those weak androgens like DHEA. The normal adrenal gland looks like a triangle, right? It's right here. That's the adrenal right there. Okay? There's a liver, spleen, adrenal gland. When you see a mass in there, it becomes more circular, and the adrenal on the right drains into the renal vein, and the adrenal on the left drains into the adrenal vein, and on the right drains into the vena cava. So it's important to note if you're doing any kind of lateralizing blood tests, or when you're doing surgery, to where that vein drains into, because that's important. So adrenal masses, let me go back here, is a mass greater than 1 centimeter. Usually they are non-functional or hyperfunctioning, because all adrenals function. They can be benign or malignant, and 80% of these are benign. So most masses are benign. These incidental masses are found in routine imaging. They are fat-containing. Most adrenal is a lot of fat, and usually there's no signs or symptoms. So most of these benign adrenal incidentalomas are smaller than 4 to 5 centimeters. Follow-up for size of these patients if the size increases, is warranted to determine future therapy. We'll go over a lot of that on this. So benign adrenal masses are adrenal hyperplasia, adrenal adenoma, myelolipoma, cortisol-producing adenoma, pheochromocytoma, and the adrenal aldosterone-producing tumor, which is also called Conn syndrome. Malignant masses are adrenocortical carcinoma. They're very rare, and metastases to the adrenal. The adrenal has a lot of blood supply, so metastases are quite common, actually. Now, how do you assess these? History and physical. Most patients don't have any signs or symptoms. I'm still getting something here. I hear it. I think it's these microphones. Sorry. You're out. Okay. Symptoms can be very vague at times. Like, you'll talk to a patient, ask them about headache. You'll ask them about what they're feeling. They might get some flushing. They might say they get some sweating spells. They might get palpitations, feel their heart racing. And these are usually paroxysmal, meaning that they don't occur all the time. They happen and they go away. They happen and go away. They can get shortness of breath. Can you turn that down a little bit, the microphone? Because it's kind of like reverbing or something. These patients can also get tremors, weakness, fatigue. The signs are, if the patient has an adenoma causing excess cortisol, is Cushing syndrome. They can get high blood pressure and multiple medications, as well as low potassium under laboratories. Now, Cushing's disease, I'm putting it on here to note, most of urologists aren't going to treat this, but just so you know, Cushing's disease is like a person on prednisone, right? They have high steroids. So what do they have? Excess cortisol. They get depression, mood changes, anxiety. They get central obesity. They get easy bruising. They get diabetes, hypertension. So that's excess cortisol. We don't usually deal with these patients as urologists. This goes to endocrinologists. They deal with this. But just so you know, it's in the realm of diagnosis. And when you diagnose and do a workup for an adrenal mass, you're going to diagnose it with the laboratories you have there in case it wasn't diagnosed or underdiagnosed. So two things that produce cortisol and hyperfunctioning, masses and hyperplasia. So a person can have hyperplasia or enlargement of the adrenal gland, just making more of that cortisol in your body. Pheochromocytoma is another condition of the adrenal gland. That is a very rare benign neuroendocrine tumor. It runs in families. It's associated with genetic defects. What you see in these patients is that, again, that burst of norepinephrine, epinephrine throughout their body. So they get usually a chronic hypertension, and they're on multiple medications. They're on 2, 3, 4 medications. You can't control their blood pressure. It keeps going up and down, depending on what happens to them and their activity levels. You'll see patient complain of headache, maybe, sweating, palpitations, tremors, shortness of breath. And these aren't always just, they're subtle sometimes, right? They're not always just present and they're there, not in your face. You question the patient, and she may have this, or he may have this. They don't always have them, but goes, yeah, I do have that, or I do have that. That does come and go. So they have these kind of, attacks that are just not persistent, but come and go, and they don't really realize it. And what happens with them is when they get these attacks, they get panicky and they get anxious. So panic attacks are very common with pheochromocytoma. It's that catecholamine excess, secretion, epinephrine, norepinephrine rushing through your body, causing all those issues. So all patients with adrenal masses need to be screened for pheochromocytoma. And I'll tell you an interesting story. There was a patient who came to my office, sent by an endocrinologist, had an adrenal mass, and I talked to the endocrinologist, said, no, it's not a pheo, it's not a pheo. Well, we did all the workup for it? Yes, we did the workup. I took the patient in the operating room. We insufflated the belly to do it laparoscopically. As soon as I touched that adrenal gland, guess what? The blood pressure went to 250 over 150. The anesthesiologist freaked and said, oh my God, what's going on in here? And I said, what happened? He said, the blood pressure just spiked, went crazy. That's a pheo. I go, yeah, you're right, it's a pheo. We had to stop the operation. The patient had to go to get back to the endocrinologist, did the workup. Certainly it was a pheo. I guess they didn't do the workup ahead of time, and then got blocked, and we took care of the mass. So it's critical. Any adrenal mass, you need to rule out pheochromocytoma. Dangerous. Why? Blood pressure goes up. Stroke, stroke, stroke. You cannot miss that. So you have to have a strong suspicion for this rare disorder, because this is very rare. It's 1 in 8 million people, right? You got to check the urinary fractionated metanephrines. These tests are highly sensitive, highly specific for pheochromocytoma, neuroendocrine tumors, but in the presence of an adrenal mass, that's definitely the highest diagnosis, is that it's a pheochromocytoma. The metanephrines, you can test these 2 ways. So that norepinephrine and epinephrine being formed by the adrenal gland, right? That comes in the plasma as plasma metanephrines. So you can test plasma metanephrines. Now, some labs don't have that. Most labs nowadays do have that. They do have plasma metanephrines. But these will be high in a pheochromocytoma. The urinary fractionated metanephrines, so they'll give you free metanephrines, and they'll give you the homovanillic acid and the vanillamandelic acid. These are 2 byproducts of that norepinephrine and metanephrine being secreted in the urine. So you would do a 24-hour urine collection to collect for these things, and that's all in one of the click boxes in Epic. Very nice for you. So these are what we test for pheo: blood plasma and 24-hour urine. There are extra adrenal gland pheochromocytomas you should be aware about. You can catch those on most of the imaging. Most of the time, the patient will be sent to you for an adrenal mass and then need to do a workup to see if that's functional or non-functional by questioning the patient, by history, physical examination, and the laboratory tests. So in the field, most patients will come to you already having scanned for the adrenal mass and the evaluation of the adrenal mass. CT scan, MRI are great for fetal chromocytomas. I'm going to show you some pictures of that. MIBG scan is a scan to look for multifocal disease in patients with neuroendocrine tumors and extra adrenal pheo, which is only 10% of cases. PET CT scan can also identify multifocal disease.